Hello, hi. Today I'm going to talk about type 2 diabetes in diagnosis and management in adults. I'm Noor, one of the GP registrar, currently in my second year of training in the UK. So this is quite a common topic which we actually learned in our latest tutorial, so I thought I will share with you. So just a definition of type 2 diabetes is a persistent state of hyperglycemia due to both combination factors, due to deficient insulin secretion, where the pancreas is unable to secrete enough insulin, and also there's an element of resistance slash insensitivity to insulin action. It is the most common chronic condition in the UK, and currently in 2021 there's about 4.9 million diabetic people living in the UK, and 90% of them are type 2. These are some of risk factors that can make someone develop diabetes. The first and foremost is obesity and inactivity, and especially with the current modern living and pandemic, the risk factors is higher than ever. Family history, so if someone has diabetes in the family, then you're more likely to have diabetes. Ethnicity, Asian, African, and Afro-Caribbean are 2 to 4 times higher risk of getting diabetes. History of gestational diabetes, diet, especially if they're eating a lot of high GI, glycemic index diet, like white rice, white bread, they're at high risk of developing diabetes. Drugs treatment like statins or steroids, and other medical conditions like polycystic ovarian syndrome or metabolic syndrome, and even people who are born preterm less than 35 weeks are deemed to have higher risk of developing diabetes in later adult life. The HbA1c is more than 48 or 6.5%, and fasting plasma glucose is more than 7, or random plasma glucose more than 11 with symptoms or signs of diabetes. If a patient is symptomatic, so only a single abnormal HbA1c or fasting blood glucose can be used. But if asymptomatic, then they need 2 different readings, so the result will need to be repeated. So common symptoms of diabetes include polyuria, polydipsia, extreme fatigue, blurry vision, recurrent infections, which are slow to heal, tingling in the feet or hands, and dry itchy skin. And if we are faced with these symptoms, then probably need to test them for diabetes if we're suspecting them. Children, in pregnant women, or if they're having symptomatic diabetes less than 2 months, because HbA1c measures the previous 3 months reading. When they're acutely unwell or they're taking medication that can itself cause high blood sugar, such as steroids. If they have acute pancreatic damage or renal disease or HIV, and also it needs to be interpreted with caution when they have hemoglobinopathies or severe anemia or thalassemia. So in this condition, probably need to get advice from the pathologist. But in pregnant women, way to diagnose diabetes is by doing oral glucose tolerance test, OGTT. The CKS NICE website, they highlight the importance of individualized care. So each person have their own care of diabetes according to their age, preferences, comorbidities, and risk of side effects. Every new diabetes need to be referred for education, DESMON, which is Diabetes Education for Self-Management for Ongoing and Newly Diagnosed Diabetes. We can direct them to the website www.desmond.nhs.uk. Also, we need to let them know and their carers know about their support network in the Diabetes UK website. Highlight the importance of lifestyle advice such as diet, exercise, weight loss, because lifestyle advice alone actually can reduce the risk of about 50% of developing diabetes. Treatment-wise, like I mentioned, first and foremost treatment of diabetes is lifestyle. Diet, exercise, weight loss, alcohol, smoking can reduce the risk by 50%. And then if they are not well controlled by the lifestyle, when we consider drug treatments. At the same time, the third is to monitor complications of diabetes. Let's go on with the drug treatment. First, we will start with monotherapy drug treatment. First line of medication is metformin. This is due to the cardiovascular benefit. We usually start metformin standard release and very small dose, 500 milligram once a day. And obviously, we want to increase, we need to increase it slowly to prevent patients from having side effects. We need to monitor the renal function before and also during treatment. If the patient started to have have a lot of side effects from the metformin, gastrointestinal upset like pain or diarrhea, vomiting, then we should consider switching to modified release. Usually this helps with the side effects. So this is a bit of busy slide, but basically this slide summarizes the NICE advice of diabetes management. So as I mentioned, the monotherapy. So first and foremost, we will start with metformin. This is because of the cardiovascular benefit. So if lifestyle alone can't control the HbA1c, and HbA1c rises above 48 despite lifestyle, then we start metformin. Even after metformin, if the HbA1c continue to be high up, more than 58, then we consider starting a second drug. So basically any of these tablets below, either sulfonylurea or gliptin or pioglitazone or gliflozin. And this is the aim of getting the HbA1c down to 53. I'll go along describing all these different medications. But the second line, when we want to add second drug, any of the drug is okay. If the HbA1c continues to be more than 58 despite being on 2 tablets, we will add the third drug. So if they are on sulfonylurea, then we'll add the gliptin, or we can add basically we can add any of these 3. And at this point, we could consider insulin therapy with the aim of getting HbA1c down to 53. And the third is if the triple therapy is not tolerated and not effective, then we can consider metformin, sulfonylurea, and GLP-1 mimetic. The reason why it has strict criteria of using because of the cost. So this is staircase if we can't use metformin. If without metformin, then basically we can use any of this with the aim of getting HbA1c down to 48. But if they are on sulfonylurea, we aim the HbA1c down to 53. And then as the first intensification, so if HbA1c is still not controlled despite monotherapy, then we add the second drug. So any of those drugs, either sulfonylurea or gliptin or pioglitazone, with the aim of HbA1c down to 53. And then obviously if we still not well controlled diabetes, HbA1c is still more than 58, then we can consider insulin at this point. There are contraindications for pioglitazone, such as fractures, heart failure, uninvestigated, we have suspicion of blood cancer, or in the care of the elderly. So this is just a diagram summarizing all the different diabetes treatment. Okay, so the first line, like we mentioned, metformin because of the cardiovascular protection. But after that, all the medications kind of equal. And metformin also actually help weight loss and low risk of hypos. With the rise of the new diabetic medications, glycoside and insulin are the last options that we consider in my practice anyway. This is because both of them causes hypoglycemia and weight gain. So usually we'll put them at the bottom of the list. Gliptins, there's low risk of hypos, but it is one of the least effective drugs. And the gliflozins may result in weight loss, well tolerated. It's better in patients who have cardiovascular problems, shown to be for patients to have reduced admissions if they have heart failure. And there's also some renal protection as well, but need to aware of the risk of having euglycemic decay. Obviously, in all the medications, we need to give the patient advice about sick day rules. The third one is GLP-1s, which is liraglutide. It is expensive and injectable, and it can result in weight loss. It also has some renal protection. It has improved cardiovascular outcome. Actually, this only can be started in the secondary care in the UK. And the third one is a pioglitazone. Is safe in renal disease. But it is most useful if patient has central obesity or very high insulin resistance. But unfortunately, it can't be used in patients with heart failure. So in my practice, what they've advised is basically if the patient, first is we check whether the patient weight and the patient's kidney function. And the first choice that we will go for after metformin is the gliflozins. And then if it's still not well controlled, then we go down to the GLP-1s, the liraglutide. And then obviously glycoside is the last one, but the third will be the gliptins. So we will try to add the gliflozin if the patient has the weight is okay and the EGFR is okay, then we will start gliflozin. And then if it's still not controlled, then we're thinking of GLP-1s, then we will refer them to secondary care to start the liraglutide. Or if they're not suitable, then we start gliptins. But Glyphosate and insulin will be the last choice because of the side effects of weight gain and also hypoglycemia. So complications of diabetes is very important. We need to monitor them annually. So there's a microvascular and macrovascular complication. So they need annual blood tests, annual blood pressure checks, food check, eye check, make sure they have the annual retinopathy checkup, checking their cardiovascular risk factors, and checking their lipid profile. Hopefully you found that helpful. If you have any questions, please comment down below. I will upload more videos about all tutorial topics so that other GP trainees will find this useful as I have. Thank you. Bye.